the other guys were a bit too busy, which seems to be a recurring theme. And we've got Mr. Patani as well, who's an oncoplastic surgeon at UCH, active in teaching and research and stuff. So I think we're very privileged to have him. He'll be giving some nuggets of wisdom now and again. I will run through this quickly. You guys are probably familiar with this now. It's not easy, average, difficult when we assign one of these colours to the questions. It denotes more the frequency and danger of conditions. Most of them are green because I think breast, for us lot, like regarding UCL, is quite a straightforward topic. I've put a couple of yellows in later on because I know you guys like a mix of difficulties. We've not actually got any red ones. But after you guys said last time that you liked the spot diagnoses section in Derm, we're going to do a little one again where I've got some random tough conditions for you to try and diagnose. Is this being recorded? Yeah, it is. So yeah, we're going to start on benign conditions. They're going to be sort of the minority of the session, but we'll mention them because they're really good kind of GP topics. And, you know, combined, they're very common. And then the bulk of it will be breast cancer, which is obviously a very important topic. So we will start on the first question. This is a very vanilla one, but I've included it because it's almost a guarantee regarding coming up in the exam, just because it's such a common presentation. So Isaac, you can feel free to close this whenever you want. By the way, the session's not going to be that long, hopefully. I imagine some of you are off to watch MDs and whatnot. So yeah, we'll aim for an hour today. Isaac, do you want to close that? I imagine everyone's cottoned on to what we're going for. Well, there's a bit of a mix, which raises a good point. So I was thinking this was straightforward fibroadenoma. So that's a firm, mobile lump in a young woman. Can be painful, can be without symptoms. It's interesting that 30% of you went for option A. So she's so young that, like, she's under 30, so you don't have to 2-week wait. You could do, maybe you'd refer and the breast service would be like, why are we getting these unnecessary referrals? But as far as NICE guidance strictly says, as this is an under 30, she doesn't need to be referred. We've got more on the 2-week wait criteria later. So yeah, when it comes to fibroadenoma, if it's just a lump, i.e. it's not painful, you don't do anything, you just leave it. You wouldn't remove it for cosmetic purposes. If it did start to cause pain, which it can do, then you'd be treating the pain basically, not the lump itself, so you get rid of it. We've got another question. Let's see what we've got. We've got an interesting spread again. Okay, so this is a cyst. I think even outside of breast, in any context, if someone describes a soft fluctuant lump, like ENT's got quite a few, you're thinking cyst. So they can be lactational or non-lactational. I believe a lactational cyst is like a galactocele, basically a buildup of milk in the breast. So this was a young woman. I didn't explicitly say she was breastfeeding, but she's got a newborn with you, so it's kind of implied. And she's got some discomfort. That's because there's a bit of a mass effect from this buildup of milk on the adjacent tissue. The best thing for her to do in the first instance is just massage it out. Obviously, if it were a non-lactational cyst, it might be a bit different and you could refer for removal because of the pain again. I didn't put this in the question, but if you draw your eyes to the bottom, you'll see a buzzword for this kind of question might be the halo sign. So, you know, if this woman or another woman went for assessment of this lump, then that's what would be described in the question is the halo sign. It's just a classic buzzword to learn for an SBA in case it comes up. So here's another one. Interesting. We've got another spread again. So we've got some good points. So this was fat necrosis. Someone else took control. Can you not? If I said that it were an obese woman who described previous trauma to the area, then it'd be even more straightforward. But like the classic exam presentation is a lady has trauma to the breast, and has subsequent kind of painful lump, which is an area of fat necrosis. I described a bruised area. You can sometimes see that over the top. Interestingly, though, even though it's a benign presentation, a firm, painful lump is exactly the same way that cancer can present. So all of these need to be 2-week weighted. I know that's kind of contradictory to what I said earlier in the lady who was under 30 and had a lump. But this, I understand. I think you have to refer all of these basically. Unlike the cancer, Mr. Patani.
So Edward, I would agree with that. Fat necrosis can feel very irregular and hard and suspicious. So when you examine it, it often doesn't feel like a smooth, rounded lump. It feels like a patch of very irregular, thickened tissue. And it's also possible that people have a cancer in their breast, and when they've fallen down or injured it, it just happens that that area has become bruised because it's had direct trauma to it. So it's not always the case that a bruised area with a lump underneath is fat necrosis. Sometimes you can have an underlying cancer and they happen to knock it against something when they fall down the stairs or something, and the area overlying it becomes bruised. So it's worth referring all of these. They're very difficult to diagnose clinically, but the suspicion and the sequence is very classical here. And it's sometimes young women when they've got children, they're breastfeeding, the children are kicking them and punching them.
And it's interesting, you said they feel very irregular as opposed to the fibroadenoma, which are smooth. An irregular lump, I think, in radiological terms, you would describe as a spiculated lump, which is kind of a bit of a nasty, suggestive term. So spiculated, irregular, kind of same. It's not a nice, smooth mass. We've got another, oh, I don't know if I ended that. Hang on, I'll get the slides back up. I think that must have been me. Let me skip through. We've got a few more slides on benign stuff. Here's another one. Oh, the stop presenting button is kind of overlapping with my little slide navigator, so I pressed it by accident. Right, let's see what everyone's put. We've got another spread. I'm surprised by all this. So this, I've pressed it again. I need to be more careful. Hang on. I'll stop doing this. I promise I won't do it again. I need to look where I'm aiming my mouse. So we've gone from discrete lumps to sort of generalized lumpiness. So fibrocystic change is what I was getting at, which feels like irregular tissue or sort of lumps throughout. I was a bit vague in UCL style and described bilateral pain now and again. The pain that I've described is cyclical mastalgia, which is basically breast pain driven by the menstrual cycle. And it has an association with fibrocystic change, and with another thing as well. We might come back to cyclical mastalgia later on. I don't want to spoil it for you. But yeah, the best thing to do, you don't really want to go chopping this out because it's diffuse. It's not something that you could do easily. So the best thing is just kind of wear a supportive bra, take analgesia, and just sort of try and get on with it. So a summary of what we've gone through. Benign breast lumps, I think this is sort of similar to what I went through with you guys when we were doing acne. It's easy to diagnose the condition. So you're not going to get a whole load of points for doing that, but it's more about kind of knowing how to manage it. So the first one was a firm lump in a firm mobile lump in an under 30. Screams fibroadenoma, and basically in exam land will always be that. They can be painless or painful. And you can consider referring them. That's what the NICE guidance says, consider. It doesn't say you must. So it's kind of, in reality, up to the GP, but in exams, as it's a grey area, you don't. A soft fluctuant lump, as opposed to a firm one, think cyst, and they can be lactational or non-lactational. A firm, painful lump is fat necrosis, and will have a history of trauma, commoner in overweight patients, and must be referred for the reasons we discussed. You know, it looks like cancer, or you can't distinguish between the two clinically. And lumpy breasts with cyclical mastalgia in a younger patient, think fibrocystic change. On question banks and what have you, it's called fibrocystic disease. I don't know whether it is a disease. It's a bit of a nasty way to describe it, but there you go. We'll move on. I'm paying really close attention to my stop presenting button now. I'm going to try and stay away from it. Okay, most people got this. So duct ectasia, or sort of retraction of the nipple. This can be the telltale sign of cancer, but note that this lady had it bilaterally. So you're unlikely to have coincidental bilateral cancer, each causing retraction of the nipple. So yeah, mammary duct ectasia, or just duct ectasia. Interestingly though, I haven't got a question on this. Can anyone put in the chat? I'll pay attention to the VVox one. Isaac, could you? I've got it. Can anyone put in the chat how you would manage this? There's not a slide on it, but orchidectomy. Can we have serious answers only, please? Depends on if it's bothering the woman or not. Kind of. Microdocectomy. So even though stop smoking, that's a good suggestion. What does ectasia mean? Duct ectasia. In presentational terms, it means retraction of the nipple like this on like a cellular level. I'm not really sure. So basically, what I was getting at, you would 2-week wait this, even though I've just told you it's bilateral, probably not cancer. She's 50, and this can be a sign of cancer. So you would have to 2-week wait this regardless, even though it's unlikely to be due to that. Anyway, I think that's enough said about nipple retraction. Isaac, don't give it too long on this one. I realise I've spoilt it already. I didn't plan to mention this in the earlier slide, but it's worthwhile running over again. So we've moved on from lumps to nipple retraction to breast pain now. Yeah, you all know exactly what I'm getting at. So associated with fibrocystic change, and that's what I want you to think in a younger patient. In an older patient, it can also be associated with duct ectasia, which is more likely. So we've said enough about this. Menstrual pain associated with these two conditions. Yeah, okay. So this is mastitis. I've presented it again as a condition that you see in breastfeeding women. I've done that because it's commoner in those patients. You can have mastitis in a non-breastfeeding woman, which would be likelier if she were a smoker, but common things are common. So we've gone down this route. I guess from the way you guys have voted, you all kind of realize that the first thing to do is 2 days of manual expression. So that's not just having the breastfeeding infant withdraw the milk, it's also kind of massaging it out. So she's had this before, so she knows to do that. She's done it for 2 days. The thing to do, if that doesn't work, is to go on to a short course of antibiotics. And if you look at my little kind of flow diagram-ish kind of thing, it's worth noting that alongside these two steps, you breastfeed throughout, because the benefit to the infant of being breastfed throughout kind of massively outweighs the drawbacks. And so we'll talk about, again, reasons to go on to antibiotics. So the first one we mentioned, you fail or 2 days of manual expression doesn't sort the problem. Also, if there's a nipple fissure, which is basically like a slit in the tissue, I think that's from the infant being a bit bitey, or if for whatever reason you culture a sample of milk and it grows a microorganism. So these are the three things. And there's the red bit of text. Can anyone tell us the likeliest organism? So do you routinely milk culture? I'm not sure. Maybe Mr. Patani can tell us about that. I was a bit baffled when I read that that was an indication for antibiotics.
So a couple of things to say. The milk is not usually sterile. It's usually got some microorganisms you can culture with extended culture. But it can be very useful, particularly in the community where you're sometimes reluctant for GPs to put needles in and get fluid directly out of the breast. So it's a nice available liquid that you can send for microbiology, and it can guide your antibiotic choice. The reason that mastitis is important, twofold. The first thing is that mastitis can be treated conservatively by following the advice that Ed has said, and prompt antibiotics with appropriate antibiotics that cover the right things, that are safe for mother and baby. You're trying to avoid an abscess developing, because that will require hospital involvement with ultrasound guided aspiration. And if that fails, women end up having an operation to have an incision and drainage of an abscess, and the skin can become necrotic, and you can have all sorts of long-term sequelae, including a milk fistula developing through your operation wound. So it's a disaster, and all of these patients with these complications could have potentially been managed better very early on, right at the beginning, by someone understanding the significance of a bit of mastitis, rather than letting it fester and then someone turning up to A&E with a temperature of 40 and a bit of black skin over their breast that needs to be operated on. The second reason mastitis is important is if you do a Google search of skin redness and breast lump, inflammatory cancer is about the first 1,000 hits, and 99.9% of women don't have inflammatory breast cancer, but every woman with a bit of redness on their breast comes to see you in the NHS or privately because they are convinced they've got inflammatory breast cancer because it looks exactly like the picture on the internet. So it's a very important topic to know about.
We may or may not have a slide on it later on. Yeah, you've all said Staph aureus, so that's correct. That's the likeliest organism. I enjoyed that input, Mr. Patani, but I'm afraid you've spoiled this question. So we'll go on. Yeah, the investigation of choice to confirm an abscess is indeed ultrasound. Management is incision and drainage. You guys know how to manage an abscess. It's kind of the same regardless of the anatomy. So yeah, it's a complication of the mastitis, and it needs to be resolved. So we'll go through.
Could I just come in on that? So the management of the breast abscess is incision and drainage is your sort of last resort. Ideally, unlike most abscesses in the body, you would persevere with antibiotic treatment, and you would do regular, sometimes 2 or 3 times a week, ultrasound guided aspiration to try and empty the contents. The reason you try not to operate on breast abscesses is because obviously it causes cosmetic problems, and they're usually in the context of smokers who don't heal, diabetics who don't heal, and lactational women who may get milk fistulas. So we often persevere longer than you think would be sensible with antibiotics and repeated ultrasound guided drainages. But in most other settings, say for example, if you had a groin abscess, you would never go down the route of antibiotics and ultrasound guided aspiration. You would always go for incision and drainage. But in the breast, it's slightly different.
Okay. There's a question in the chat. From the question, how would you know it's abscess and not mastitis? So mastitis is inflamed and painful, and abscess is the same, but with a palpable lump. So we can see here there's tender, firm, palpable lump. So it's the same disease, but with a sort of collection that's growing microorganisms in there. So summary of what we've just gone over: nipple retraction and discharge, think duct ectasia. Our Lady had it bilaterally, but unilaterally is a red flag, which we will mention again later. We've talked about cyclical mastalgia, so menstrual cycle driven pain, commoner in fibrocystic change, and duct ectasia. An inflamed breast, if you hear hooves, don't think the zebra, don't think inflammatory breast cancer, it's probably mastitis. Commoner if you're breastfeeding, if not, commoner in a smoker. First thing to do is 2 days expression and then a short course of appropriate antibiotics. If there's a nipple fissure present, or if you culture the milk, then go straight to antibiotics, but they're a bit niche. And a common, or not common, important complication of that is an abscess. So serial ultrasound guided aspiration with antibiotics. So let's move on. You might be getting deja vu from this vignette. Okay, nice. So I've done it, I've basically copy and pasted the vignette just to make the point that the age thing is important. So this looks like a fibroadenoma, but suddenly it's not 24-year-old like we had before. She's 10 years old, she's over the 30-year threshold. So you need to refer this. So yeah, most people got that. The one or two people who didn't, 30 is like the key differentiator when it comes to whether or not to refer. And I've given some clues to this already. So I'm interested to see how the results for this one go. So I'm being anal about this one, and we've got 100% miss rate, which is interesting. We've talked about nipple retraction or duct ectasia being a red flag for cancer, but if you're being super strict as far as NICE guidance goes, she has to be over 50. This lady's 45, so strictly you wouldn't refer this. In reality you would, but if we're playing the NICE guidance game, you don't. So the next slide, let's go through the NICE guidelines. I think we've worked through most of these. So 13 over with an unexplained lump, that was the first question in this section. And it can be painful or painless. 50 or over with unilateral discharge or retraction, which is what we saw in that lady, or other changes of concern, i.e. Paget's disease of the nipple, a bit of nipple eczema. Mr. Battani, are there other things that would constitute other changes of concern in this context? Because I couldn't think of what else to add to that list.
So with regard to the nipple, they do get very anxious about skin changes. So if you develop things like eczema or flaky skin that doesn't respond to topical steroids, or it's refractory to treatment with topical steroids, that's a reasonable thing to refer. So you've mentioned discharge, you've mentioned retraction, you've skin changes I would put in there.
Okay. I'm not going to talk through the rest because I think consider 2-week wait isn't good SBA fodder. SBAs like to be black and white, so we've talked through the key points, so we'll move on. Let's see. Okay. So we'll go through each option. Women who are referred for screening undergo examination, imaging, and biopsy. So that's what happens to women who get a 2-week wait referral. They go to a triple assessment. I think some or all of you will have had a day or two where you go to that. It's quite a cool clinic. The imaging of choice in the screening program is a mammogram. Screening offered to women aged 45 to 70. Currently, it's all women aged 50 to 70. Some of you will be aware that that's being broadened to 47 to 73, but the age bracket that applies across the country is still 50 to 70. Screening offered every 3 years. Yeah, that's right. Women over 70 are not eligible for screening. So they won't be invited like those in the 50 to 70 window will, but they can request a screening and they can still go through that pathway. A positive screening result is diagnostic. There aren't many instances in which that's true. I think we were talking vascular before, and if you screen a AAA that's massive, you made a diagnosis there, but I couldn't think of any other instances in which a screening result was diagnostic. It's kind of a prompt to go for diagnostic investigations. So we'll talk a bit more about the screening program. So we've said it's a 3-yearly mammogram for those between 50 and 70. If someone's going to get it outside of the 50 to 70 window, it needs to be because they're older and they've requested it, or if they're younger, because they have a strong family history. So we've got a slide on that, on family histories and BRCA genes and what have you. Basically, anyone can go for screening, but they won't necessarily be invited to, like those between 50 and 70 will. So it's, as I've said, it's mammography with 2 views, just like you do in orthopedics. So caudocranial, so bottom to top, and medial-lateral side to side, so you can get kind of a good 3D impression. And there's 3 results that can come from mammography. Either it's a satisfactory result or normal, and they can just go back to the community and come back again in 3 years. If it's unclear, you'll do another mammogram to try and confirm what exactly is going on. If it's abnormal, then you would go for the diagnostic investigations that I was talking about, i.e. triple assessment, so exam, imaging and biopsy. So yeah, just 2 brief things here. The key points: you must refer over 30s with an unexplained lump, over 50s with suspicious nipple changes, i.e. discharge, retraction or eczema. The screening program, I've included this in GP section. It's not strictly GP, but it's kind of a breast cancer in the community thing, so I think it works well. 3-yearly mammogram for those between 50 and 70. If you're outside of this bracket and you want to go, you need to fit certain other criteria, which we'll mention again. And you either get a normal result, an unclear result, or an abnormal result, and you act on those accordingly. So now we're going to move on to a different topic. Okay, let's close the poll. Nice. Yeah, so over 30 with an unexplained lump. So she is going for triple assessment. The imaging of choice depends on the age. If she's 35 or over 35, she gets X-ray. If she's under 35, she gets ultrasound. And I think that's due to the density of breast tissue. Younger women tend to have denser breast tissue, which favors use of ultrasound or doesn't favor use of X-ray. I'm not sure which way it is, but X-ray is better for the older patients and ultrasound better for younger patients. And that little yellow P4 there, we're about to come onto it. I don't know whether these scores, the scores that you get at triple assessment, are going to come up.
Can I just take you back to that previous slide, Ed? It's just that number of 35, the age gets changed. So at the moment, UCLH is mammogramming people over 40. When I first started at Norfolk Park Hospital 10 years ago, they were mammogramming people over 35. The problem with mammogramming very young people is the breasts are dense, so the whole thing is just a complete whiteout, and you can't see all of the interesting things that are white, like cancer and calcifications. And as you get older, the breasts become fattier and it becomes more and more accurate to do a mammogram. An ultrasound is generally only useful for something that you can feel, to characterize. It's not a good screening tool for people where you can't feel any lumps, because it's only likely to find incidental things that are of no clinical significance. But it is useful to have in there for people under the age of 40, because most of them will be expecting some sort of scan.
Okay. Interesting, in the chat, some people are saying they've been told 40, someone who's taught at the WIT was saying 35. So if it's a grey area, maybe you won't get asked about it. But the principle still holds. Denser breast tissue favours ultrasound. Perhaps I should have identified and clarified this grey area beforehand, but maybe you guys can do that yourselves. So triple assessment, you get 3 scores that kind of give a composite score regarding the suspicion around the mass, and it's kind of similar to the TNM system, same idea. So the first thing, examination, gives you the P score, P for physical or for palpation. It's a bit of an OSCE thing, but the breast is divided into times on the clock, and you examine and kind of note your findings according to that. A lower score, like P1, is better. P5 is the worst. And P5 would be a very firm, irregular mass, like we talked about earlier, as opposed to P1, or a P2 rather, which would be a smooth mobile lump. So you get your P score, and then you go into imaging and you get your M score for mammogram, or you get your ultrasound score, and it's the same thing. You get a score from that part of the assessment. If you have palpable growth in the axilla, which can be breast tissue or kind of nodal metastasis, you image with ultrasound. And then you go on to cytology or biopsy, taking some samples, and you get a score for that. And it works the same way, so it's easy to remember.
Can I just take you back?
Yeah.
In cytology, it's slightly different because C1 is an inadequate sample. So, so C1 in a cytology is an inadequate sample. The only circumstances under which C1 would be acceptable is if you do an FNA of something like a lipoma, where you're not expecting to see any epithelial cells, and you get no epithelial cells. That would potentially be consistent. But otherwise, a C1 cytology always means inadequate sample. And the other thing I would add is that with the B system, the B5 has got 2 gradings, A and B. I don't know if you come on to describe what they are.
No.
So B5A is non-invasive cancer, so DCIS, and B5B is invasive cancer. And the way I used to remember it was that B5A, the cancer cells are sitting above the basement membrane, so they're non-invasive, and B5B, they're sitting beneath, or they have breached the basement membrane, so it's invasive cancer. But this is a really good system. It's worth going through this, but C1 is different and B5 has got A and B.
Okay. I've included it. I don't recall having any UCL questions on it, nor questions in the question banks. I've included it because it gets mentioned a bit on your breast week and in the UCL breast teaching, so it's something to be aware of. Maybe it'll come up in the OSCE, I'm not sure, but yeah, just kind of included it for the sake of completion. So triple assessment, ultrasound for those under 35 or under 40, maybe depends where you are, maybe I've got it wrong. Mammogram for the older people, you get a combined score from the 3 aspects of the assessment, and then you kind of decide accordingly how to approach the situation. Okay, we've got a different topic. And we're over halfway and sitting at about half an hour, so that's a good sign. Okay, interesting. Those of you who've put smoking and alcohol history are going to say this question's not black and white, you don't know what you're talking about, but kind of trying to make a point. There's some things that are very well recognized kind of risk factors for cancer, and some that are protective. So the risk factors, or the risk increasing factors, are those things that increase your lifetime estrogen kind of dosage or exposure. So if you have early menarche or late menopause and you're exposed to a longer period of kind of high levels of estrogen, it increases your risk. So let's go through the different options. Has 3 children, multiparity, reduces lifetime estrogen and is therefore a protective factor. Use of IUD, I put that in because hormonal contraceptions like the pill, Mirena coil, what have you, they're giving you estrogen, they're driving the growth of cancer, but the IUD is non-hormonal, so it doesn't. Menopause at 50, that's a normal age, so I wouldn't consider that to be the late menopause that would increase your risk. And smoking and alcohol history. This is a bit grey, I'll admit, like any amount of smoking alcohol is going to increase your risk, but that alcohol consumption is within the recommended allowance of 14 units a week, and 5-pack year history, it's not huge. So yeah, just wanted to make the point that kind of is outlined in this table. Things that give you more estrogen across your lifetime drive breast growth, increase risk.
And these are really good sort of questions for an exam, but I think I mentioned in the small group teaching that the 3 biggest risk factors for breast cancer are female gender, age, and family history, and none of those are modifiable. You are what you are, despite all of the political correctness. And the second thing is your age is your age, and your family history is your family history. So these are immutable things. These are sort of tinkering around at the edges, but we often get very, very excited about them. But it's very difficult to change your personal risk massively with any of these. It's all decided by your gender, your age, and your genetics. But these are all very interesting. And alcohol apparently does increase your risk of breast cancer, particularly binge drinking before the menopause. So it is a trendy risk factor to know about.
Okay, maybe I should have put age in the question. This one is a bit of a cheeky one, a bit of a naughty one. What counts as late menopause? I saw there. That's an obs and gynae question. Mid-50s, I think, maybe 55 something. Not sure. Is that speculated buzzword that I mentioned earlier? Okay, yeah, we've got a bit of a spread. So I made this deliberately ambiguous. You can't tell from the anatomical description of the cancer exactly what it is. I wanted to, well, you can tell it's invasive because it's involving different tissues. I wanted to make the point that by far and away, the commonest breast cancer is ductal carcinoma. And then within those, invasive is commoner than non-invasive. So it was more a test of your ability to recognize the frequency of different cancers rather than figure it out via the anatomical description. And I've just realized at the top of the screen, I've put a little D there that I forgot to delete. So bit of a spoiler. So yeah, there's 4 subtypes of cancer, which we've got on the next slide. Ductal and lobular, they're kind of very logical. You can guess what anatomy they affect. Medullary, which is a rare type of ductal, and phyllodes or phyllodes. I've included that. It's niche, but it's kind of an exam topic, so I'll put it in. So we'll go through ductal first, by far and away the commonest. It's your classic suspicious breast lump. Has different histological types to be aware of, but again, I've put them in for the sake of completion. I don't think you would ever have to, at undergraduate level, distinguish between those types. Another buzzword to include, to recognize, is commodone necrosis. So it's like a pustule or a commodone that you would get on the face, an area of dead tissue, and that's apparently typical of in situ or ductal carcinoma in situ. So if we go on to the next commonest, which is lobular, that's not a typical breast lump. The tissue tends to grow as lines of small uniform cells. Because it's more diffuse, it's not palpable as a lump. Medullary is a rare but aggressive type of ductal carcinoma, has an association with BRCA and is more likely to be in a younger patient. Some buzzwords I'll just read out for you: solid sheets of anaplastic cells, pleomorphic nuclei, and lymphocytes surrounding the tumour. If you want to learn those, on the off chance you get a histology question on them, fair play. Otherwise, I wouldn't worry too much. And then phyllodes, the last one. You can have benign and malignant phyllodes tumours. They're rare, and I think the key thing to take away is that they have this weird leaf-like growth of epithelial and stromal tissue. I don't think there's anything more that needs to be said about them, but they're one of those kind of exciting sounding niche exam topics that people get excited over, perhaps unnecessarily. So yeah, the risk factors that kind of drive breast growth are age, which is prolonged exposure to estrogen, pro-estrogen things like medications, not having children, and then smoking, alcohol, whatever, your genetic makeup, like whether you have BRCA mutations, which we'll come on to. The vast majority of cancers are ductal carcinoma and then lobular carcinoma. Within the ductal branch of things, invasive is commoner than in situ. And there's a couple of others to be aware of, like medullary and, oh, I was meant to put phyllodes there, rare, but, you know, exam topics. So I haven't actually got any SPAs on this section because I got kind of worn out by writing them, but basically the stepwise management of breast cancer, the mainstay is surgery. So I could have highlighted that. Surgery really is just chopping out the cancer. Before that, you want to reduce the tumor bulk or shrink it down, and you can give systemic therapy. You want to be able to do breast conserving surgery, i.e. wide local excision if you can, you know, because the woman doesn't want to be left without a breast. It's sort of unnatural in a way. You know, there's a whole sort of social and psychological area around that. So you save it if you can. And there's different factors that favour breast conserving versus non-conserving surgery, which we'll come on to. So you do your neoadjuvant to shrink it down, and then your surgery to get rid of it. And then after that, the goal is to reduce recurrence. So you can give systemic therapy like chemo, hormonal therapy, or radiotherapy. If someone has a wide local excision, i.e. they've still got breast left after the surgery, they have to have radiotherapy. That's like a ground rule, everyone gets it. If they're spread to the lymph nodes, you can remove those surgically, either in the first procedure where you get rid of the mass, or you can do it later on. If you want to manage that non-surgically, you can do it with radiotherapy. And like monitoring response to treatment, you can do imaging to see whether like a gross mass has come back. CA15-3 is a good tumor marker to learn. You know, we like different tumor markers for different cancers, so that's the one for this one. So we'll go on to systemic therapy. There's a few different options, and it depends on the phenotype of the cancer. So you have estrogen receptors, progesterone receptors, and HER2 receptors, and these relate to your hormonal therapy and your Herceptin. There's also chemotherapy alongside these two types, but because I think that's very postgraduate, very kind of oncology based, so you wouldn't have to choose between the different types of chemo, you just have to recognize that that is a thing. So hormonal therapy. I've never seen the medications that you give for progesterone receptor positive tumors, only the estrogen stuff. And you can give either tamoxifen, which is an estrogen receptor modulator in premenopausal women. If they're postmenopausal, you give an aromatase inhibitor. And the red text there next to these points shows the side effects to be aware of. So tamoxifen is a VTE risk factor, and as it's selective estrogen receptor modulator, it kind of upregulates or is what's the opposite of inhibitory? It's like it has a positive growth effect on some tissues and a negative growth effect on others. So it will have a negative growth effect on the breast, but it has positive growth on the endometrium. So that's a risk to be aware of. And then if you give an aromatase inhibitor like anastrozole to postmenopausal woman, you're kind of giving her menopausal symptoms again. You're depriving her of estrogen. So hot flushes, fatigue, things that you will learn about in obs and gynae, well, gynae. So those are the two options: tamoxifen for premenopause, anastrozole for postmenopause. That's for estrogen and progesterone receptor positive tumours. HER2 is another important receptor. I think there's a really big focus on that in year 2 in the women's health module. So trastuzumab is the name of the monoclonal antibody. The brand name is Herceptin. That's a really good drug, but it has a few side effects again that are worth learning. So it's teratogenic, and it causes a cardiomyopathy. I was thinking about writing you a tough question where a lady had cardiomyopathy and a history of breast cancer. I think that's a good SBA thing, but I couldn't be bothered. So you've given you systemic therapy to shrink down the tumor, and then you go into the mainstay of treatment, which is surgery. So this blue table shows what I was alluding to. Whether you go for wide local excision, i.e. breast conservation, versus mastectomy, depends on a few things. The most kind of intuitive one is the size of the mass relative to the breast. So if you have a big mass in a small breast, you're not going to be able to kind of get rid of the tumor via wide local excision and, you know, leave tissue left over. You have to get rid of it all. If you have a small mass and a big breast, then maybe you can play around it. If you have just one mass, then you can potentially wide locally excise that, whereas if you have multiple ones, it's not really an option. It's not worth doing multiple wide local excisions in a breast. You just play safe and get rid. So solitary lesion versus multiple ones, small versus large. A peripheral lesion favors local excision versus a central one. And of course, it depends on the patient wishes as well. So you can have maybe an argument, maybe a discussion back and forth saying, I do want this, don't want this. And you know, you have to work with the patient, it has to be patient-centered. Surgery of the axilla. So the nodes that drain the breast can receive kind of metastasis. You can, before you go for the surgery, the mainstay of treatment, this first surgery, you can palpate the axillae, and if you've got palpable nodes, you can take them out then and there. If you haven't, you can do ultrasound, and if they're then detected, you can chop them out. If not, then you don't. Or you can biopsy them at a different time. And I've included reconstruction at the bottom because it's cool. Usually I wouldn't ask you about it. There's different techniques. So you can reconstruct the breast then and there, or you can do it after a delay. You can put breast implants in, or you can use the patient's own tissues. Got a cool slide on that later on in the spot diagnosis section, one of the like flat-based techniques. But yeah, key points to take away from breast cancer management: you do neoadjuvant chemo to shrink it down, and then surgery to just remove it if you can. Whether you go local excision or mastectomy depends on a few things. Spread to the axilla, i.e. the lymph nodes, is managed with surgery, where you literally chop the nodes out, or with radiotherapy. There's also systemic therapy, which is used in the adjuvant setting, and that can target estrogen receptors, progesterone receptors, HER2 receptors. So that depends. If you have, you'll be aware of the term triple negative. That is a cancer that has a poor prognosis because it doesn't have estrogen receptors or progesterone receptors or HER2 receptors. So your treatment options are really kind of narrowed.
And it's worth mentioning that triple negative cancers sound like a distinct group, but actually, if you're talking about modes of transport, it's like saying something doesn't have wheels, it doesn't have legs, and it doesn't have wings. So it's not one thing, it's a whole mishmash of stuff. It just doesn't seem to have the three receptors that we are obsessed with in terms of classification. So while ER positive cancers are relatively homogeneous in terms of their response to endocrine treatment, and HER2 cancers are homogeneous in terms of their response to Herceptin, triple negative cancers are a complete mixed bag, and some of them are very resistant. Some of them are exquisitely sensitive to chemotherapy. So understanding triple negative disease is one of the key research areas at the moment.
Okay. So if we go back to this is a anatomical histological classification, different types of cancer here, whereas the triple negative thing, or the hormonal receptors, is more kind of cell surface molecular classification that guides treatment. So yeah, you can have different histological types that have different receptor types and crossovers and what have you. And remember, CA 15.3, just memorize that. It can be used to monitor response to treatment alongside imaging and examination and what have you. This one I have put it in. It's not like typical SPA format, but I nicked it off the amnesty, so we know UCL like it, and it raises some good talking points as well. We've actually not got many questions left until the spot diagnosis section. We'll just go through BRCA and family history, and then I think that's enough. So, bit of an unexpected spread. Interesting. So, the first one, combined pill increases risk of breast cancer in BRCA mutation carriers. That's true. It does it in all women who take it. We've talked about estrogen being a driver of breast growth. The second point, BRCA mutations give a 50% lifetime risk of developing breast cancer, i.e. if you have a mutated BRCA gene, there's a 1 in 2 chance that you'll get it. These stats kind of suggest that, in fact, the odds are even worse than that. Obviously, you can see there's a few ranges there and a bit of variability. They don't need to be memorized. Just remember that having BRCA mutation really does increase your risk. I saw it written down on the website that if you have a BRCA1 mutation, you're like 5 times as likely to develop breast cancer, and something like 10 to 30 times as likely to develop ovarian cancer, which is kind of horrible, to be honest.
And just remember that what the government and the guidelines suggest is low risk or population risk of breast cancer is already 1 in 8 women, so it's 12%. So the risk is already pretty high for even the low risk people. And the risk of BRCA mutations is a lifetime risk. So numbers like 85% are scary, but that's your overall lifetime risks. If you take a 5-year-old with a BRCA mutation, their risk of breast cancer is still pretty much 0 because they're 5 years of age. And if you take a 99-year-old with a BRCA mutation and they haven't had breast cancer yet, their risk of getting breast cancer in their lifetime is not going to be 85% because they're going to die of something else. So the significance of these numbers depends upon how old you are. And generally speaking, it's those women that are sort of in their 20s to 30s that have 50 to 60 years in front of them that are facing these kinds of numbers like 85% risk.
If we go to point C, we talked about parity or multi-parity being a protective factor. BRCA is quite nasty, and if you have this mutation, you lose the protection from pregnancy in terms of breast cancer risk. Point D, BRCA mutations tend to cause triple positive breast cancer. I don't want to delve too deeply into it and say something wrong, but one thing I found online after some research is that BRCA1, which is the worst of the two, is more likely to give you triple negative. So again, just hammering home the point that this mutation is terrible. Prophylactic mastectomy becomes more effective with age. That's just counterintuitive. The younger you are when you have your breasts removed, the less likely you are to have developed cancer or to develop them. So yeah, the BRCA genes, you've got 1 and 2, the tumor suppressors. Inheritance of the mutated alleles is autosomal dominant, which is why BRCA genes and family history of breast cancer are 2 very interlinking topics. So yeah, they're the stats that we dropped. BRCA1 associated with triple negative, BRCA2 likelier compared to BRCA1 to give hormonal receptor positive ones. This stuff doesn't need to be like rote learned. It's just to give context to why these genes are so important, why they get talked about.
And it's also important to say that only 5% of breast cancer is attributable to these genes. The vast majority of women with breast cancer do not have BRCA mutations. But if you look within BRCA patients, obviously their risk of cancer is very, very high. So it can be misleading sometimes because people think cancer is a genetic disease. That is true, but not all cancers have known genetic problems. And if you look at breast cancer as a whole, most people have got sporadic mutations which are not inherited.
Okay, so from BRCA genes to family history. Obviously, having a family history of breast cancer doesn't mean you have the genes, but it can do. So the 2 topics kind of go hand in hand. And I hate this kind of question because you know that to get it right, you have to just rote learn certain things, but that's how it is. And this was another one that I found on Amnesty, so you still like it. So let's see what we've got. This is actually the last SBA of the session, unfortunately. Okay, yeah, so you guys know what we're getting at here. There's a few things that we need to learn regarding family history and when to screen someone. So, I mentioned earlier, if you're under 50 and you have a family history, you can be screened for breast cancer. That's if you have one of these family histories. So we'll go through one relative, and then two relatives, and then three relatives. If you have one relative with breast cancer, they have to be first degree, i.e. your mother, sister, or daughter, and they have to be either diagnosed young, so before 40, or they have to have bilateral breast cancer, the first one of which was diagnosed young, or it has to be a male. So males can get breast cancer as well. So they're the three things. If that happens in your immediate family, you can go for screening. You can have two relatives with breast cancer. Note that one of them always needs to be first degree. So if you have a mother or a sister or a daughter with breast cancer and someone else in the family, then you can get screening, or someone in the immediate family and a cousin or an auntie or a niece, you can get screened for that. Or if you have someone in your family with breast cancer, or in the extended family and someone with ovarian, that's a bit suspicious and you can get referred for that. And then if you have three relatives, doesn't matter whether they're immediate family or cousins, nieces, aunties, whatever, three relatives is suspicious. So you've got 1, 2, 3 relatives, different rules. Best thing to do is just go and learn these, unfortunately. So yeah, just a few takeaway lessons. BRCA 1 and 2 give significant increased risk of breast cancer for the individual. As Mr. Patani said, not such a significant population level problem, but for the individual with these mutations, it's bad. And those family histories are worth memorizing because they're nice black and white rules, which are good for SPAs. And it could maybe come up in a GP/breast question in the exam. This woman says that both her sisters have breast cancer. What do? You would refer. So we're finished with SBAs and finished with the learning. You guys liked the spot diagnoses last time, so we've got the spot diagnoses again. There's not as many because breast has, there's not that many niche things that are worth mentioning. So anyway, we'll go on to the first one. I want it to make it a race. You can put in a chat either on Teams or on Vvox what you think this is. And yeah, fastest person gets it. Mastitis, yeah. IBC, no. Abscess. So I should be more clear. The thing that line's pointing to specifically, I've blocked it out because it was already annotated. Fissure, yeah. So I talked about fissure earlier being a prompt to go straight to antibiotics in mastitis, and this is what a fissure looks like. I think this woman's probably been bitten by her infant. This was the best picture I could get. I tried to get a picture that didn't have words all over it, but there are actually surprisingly few online. So fairly common. This one's niche, and I didn't put an SB on it for this reason. If I did, this would be a red traffic light just because it's rogue. If anyone gets it, I'll be quite impressed. Note that it's a male as well. I couldn't get a good picture of a female. Worms. Worms in the breast. Mondors, yeah, so it's Mondors. Can anyone, what's the descriptive name for this condition? So we've got the eponymous one. Anyone who hasn't heard of Mondors is going to be like, what are you on about? It's just a rogue condition that exists. Thrombophlebitis, yeah, nice. This is superficial thrombophlebitis of the breast. So it's Mondors disease. You can get Mondors of the penis as well, but that's less relevant to this lecture. This is going to be a real kind of test of speed, who can type the fastest. We've talked about this, and you guys saw this in the dermatology session. Pages, you guys are fast. Yeah, this is Pages. So this is eczema of the nipple that starts on the areolar complex and spreads out. It doesn't start on the adjacent tissue and move in, classically. And it can occur as an isolated presentation, or it can be a marker of breast cancer. Abscess. This next one, if I showed you what was under the black box, it'd be too obvious. So lymphedema, yeah, exactly. So before I show you the picture, why has this person got lymphedema? Where is that? It'll be more obvious when I take the box away. Right hand, yeah. Nerve damage from surgery, no. Axillary node removal, yeah. So the lymph nodes have various functions. They can transport chyle around, which has fat. They transport white cells around, and they also send interstitial fluid back to the main circulation. So she's had nodes removed from the right axilla because she had nodal metastasis of cancer of the right breast. And now that I've taken the box away, you can see that the right arm is a lot more swollen than the left one. And unfortunately, there's not an awful lot you can do about lymphedema, not yet anyway.
So she's actually had a radical mastectomy. You can see they've removed the pectoralis muscles as well. We don't tend to do these sorts of operations anymore. But lymphedema is a real problem. And as you say, it is basically irreversible.
Okay. We've mentioned this, or I should say Mr. Patani's mentioned this as well. Again, didn't include a question on this earlier because it's niche. Ectasia. Yeah, so there is ectasia. IBC. So I know what you're getting at there. Isaac's written as well. I don't know why you're getting involved, Isaac. So yeah, this is inflammatory breast cancer. So rapidly progressive with maybe a lump, a nipple retraction, and discoloration, but rare. If you hear hooves, don't think zebra. This is your zebra, whereas your horse is mastitis.
Yeah, but it's amazing how many people with inflammatory breast cancer have a trial of antibiotics before they hit the breast clinic. So obviously the GPs are still picking this up and trialing antibiotics on it.
Someone said, what is zebra and horse? There's a saying, if you hear hooves, think horse. It's basically a fun way of saying common things are common. So don't look at this. This is you hearing hooves and think that they're caused by a zebra, which would be rare. It's caused by a horse, which is mastitis. Or in this case, this is the zebra, but whatever. We'll go on to the next one. How would you differentiate? Would you refer? Yeah, I guess. Aliens. It's not an alien. Fat necrosis. That's a good guess. Carcinoma in situ. Implant. Ruptured implant. Yeah. So what you learn on your question banks is snowstorm sign. It's another buzzword. But I looked up snowstorm sign on Radiopedia and what have you. And the ultrasound, it looked nothing like a snowstorm, so I didn't include it. But yeah, there's breast implant rupture. Now this is Mr. Patani's bread and butter. If any of you, this is like beyond the curriculum, by the way, but if any of you guys know it, here's time to anonymously flex. This is an autologous tissue transfer method. Reconstruction, yeah, what kind? Abdominal tissue transfer, do you know the name? BBL. Trap, no. From belly fat, yeah. Tummy tuck, yeah, there is a bit of tummy tuck. All right, so this is a DIEP. You take muscle, fat, and skin from the abdomen and move it up. It's an oncoplastic technique, and I've included it not because you guys need to know, just because it's like sci-fi level cool surgery. So yeah, that's that. She's gotten a tummy tuck out of it. Unfortunately, this is the last one. So this woman's healthy. Abscesses, she's healthy. Ectopic breast tissue, yeah. Ectopic or axillary, so it can grow up into the armpit. And that's what this lady's got, like armpit lumps, basically. Third eye. Why the emphasis of healthy? Because this is benign. So she hasn't got abscesses, she hasn't got nodal metastases or anything like that. She's just got breast tissue in the axillary. All right, I'm afraid we've got no more spot diagnoses and no more SPAs. If you want me to go back to anything, now's the time. If you have any questions for Mr. Patani, now's the time. What was the last one? Axillary breast tissue. So her breasts have grown into the axillary. Any questions for myself and Mr. Patani? Can we go through inflammatory breast cancer? I'm going to hand over to the expert because I don't really know anything about it.
So inflammatory breast cancer is very, very poorly defined, despite being widely feared. The differential diagnosis of inflammatory breast cancer is basically a big red breast, and you're concerned that there may be an infection at the lowest level of your suspicions. So these patients are often treated with antibiotics, but it's sometimes in people who are not smoking, not diabetic, not breastfeeding. So why would they have a big red breast? You know, you have to ask yourself that question. If they haven't got a temperature, are there any other features of infection? Inflammatory breast cancer can also be misdiagnosed. So some cancers cause local lymphatic obstruction of the breast drainage. So you get this peau d'orange. I don't think we've seen a picture of that today, but it looks like orange peel, where you get this sort of pitting of the breast skin. And that makes you worry about inflammatory breast cancer, but sometimes it can be caused local lymphatic congestion as a result of the lymphatics being occluded by the cancer, either in the axilla or in the breast. And then the third extreme, if you like, is the proper inflammatory breast cancer, which is not necessarily associated with peau d'orange. But as you can see in this picture, there is clearly something going on here. And this is the sort of dermal invasion by the cancer cells. So the purists would like you to do a punch biopsy of the skin to prove that there is cancer within the skin, making the diagnosis of inflammatory breast cancer. Most people, though, would have a more relaxed approach to this and say that these patients have got a spectrum of illness, and some aggressive breast cancers have inflammatory components, and they should all be treated in a very particular way. So inflammatory breast cancers, unlike other cancers, are always treated as long as the patient is able to have neoadjuvant chemotherapy, because you're trying to treat this microscopic involvement of the skin. Before you start chemotherapy, it's a good idea to take mapping biopsies of which bit of the skin is affected, because after chemotherapy it goes away, but you are still obliged to remove all of that skin. So you do quite an aggressive mastectomy. And if there is then not enough skin to close it together, you have to do a graft or a flap from somewhere else. And then they all get radiotherapy. So these patients never get immediate reconstruction. They all get neoadjuvant chemotherapy, quite aggressive surgery with resurfacing if they need it, followed by radiotherapy. And then you do a body scan before and after treatment to see if they've got metastases, and you generally give them a couple of years after that to see how they go. And if you've effectively cured them, then you can go on for a delayed reconstruction. But if you haven't, most of them will relapse early and require systemic treatment with chemotherapy for disease elsewhere. But inflammatory breast cancer is a good spot diagnosis. But remember, you can get advanced cancer with lymphatic congestion. You can get infections that look quite nasty. And the treatment sequence is always chemotherapy first, radical surgery, followed by radiotherapy, followed by delayed reconstruction if they live that long. And you can get all phenotypes, ER positive, triple negative. You can get ductal, you can get lobular. So inflammatory breast cancer is something that comes up a lot, but it's actually, I've seen 3 or 4 cases in my whole career.
Yeah.
And I've seen a lot more zebras than that.
Next question. I think it's time for me to put my hands up and say I got it wrong. I realized there was a bit of a inconsistency in what I was saying about duct ectasia, nipple retraction. I said that lady who had it bilaterally should be 2-week waited. I take that back. Mr. Tony, what do you think about unilateral versus bilateral nipple retraction and how to manage it?
Yeah, so what I would say to you is that there is a difference between what the guidelines say and what the GPs do. And a lot of this is tailored across what kind of patient you have in front of you. Some patients come to the clinic to see a GP and they're absolutely neurotic, and there is no way you are going to get them to go home and calm down. So what you end up doing is you escalate the situation even more, saying, I'm going to refer you to a cancer hospital on a cancer pathway where you're going to meet a cancer surgeon. And the patients then go completely berserk. And then for the next 2 weeks, they're going absolutely ape until they hit the clinic, at which point you say, yes, you've probably got a bit of duct ectasia. There's nothing to worry about. But generally speaking, it's safer to 2-week referral people than not to 2-week referral them. In fact, we don't have a routine pathway for breast referrals anymore. Everyone comes down a 2-week pathway, and the GPs just tick a box. Do they suspect it's cancer or not? But basically, if you're in the community and you've got a change in the breast, most patients are anxious. It's not unreasonable to refer them to the clinic. And what was the specific question? Was it related to unilateral nipple retraction?
Yeah, so when I was first writing it, let me go and find it. It was quite early on. A lady had unilateral, and then I think I changed it afterwards. Yeah, here it is. And then I think I changed it afterwards, but still kept this note saying 2-week wait. So this woman had it bilaterally.
Yeah, and she's 50 years old, so she maybe she hasn't been invited for her first mammogram yet, and she's reporting a change in the nipple areolar complex. It's not unreasonable to send these people to the clinic. We see people with a lot less.
Before I go on to the next question, I have sent a link to the feedback into the Teams chat. I know it's a bit of a blag doing it. If you guys can be bothered, that'd be really great. Thanks. Next question. Can we? Oh yeah. Can we go through sentinel lymph node biopsy? So
Sentinel lymph node, the word sentinel actually means watch person or watchman, sort of a guard or a policeman, if you like. It doesn't have a huge bearing, but the idea is that the lymph nodes in the armpit are not organized randomly, they're organized in a hierarchy. And if you imagine that in the simplest terms, they're in a nice orderly queue from lymph node number 1 to lymph node number 30. And if you're Mr. Breast Cancer and your plan is to spread to the lymph nodes, you travel along the lymphatics and you get to lymph node number 1, and then you go to lymph node number 2, and then you go to lymph node number 3, and then you work your way up the tree. So the idea of sentinel lymph node biopsy is that instead of doing an axillary clearance and causing morbidity in every single person, about 20 years ago, it was discovered that you could basically do a sampling of the lymph nodes in the armpit. And if that sample was clear, you didn't need to remove all of the lymph nodes. So instead of doing random samples, we try and identify the first few lymph nodes that the breast cancer drains to. So the way that we do that is we put an injection of something radioactive into the breast. It's usually a radioactive colloid particle, and that travels up to the lymph nodes and it gets trapped in the first lymph nodes or two that it goes to. So they become radioactive. And during the operation, you can also inject some blue ink into the breast, and that travels up through the lymphatics into the lymph nodes and also stains and gets trapped within the first few lymph nodes. So when you open the armpit, there'll be a few lymph nodes that are radioactive and hot, and they are obviously earlier in the food chain than the higher lymph nodes. So if you remove these low-level lymph nodes and they're clear, you can spare the remainder of the axilla and avoid the morbidity. And the sensitivity of sentinel lymph node biopsy is 95%. So that means that 95 times out of 100, if someone has got axillary lymph node metastasis, you will find them using a sentinel node biopsy. So it does miss 5% of axillary nodal metastases, but it is much less morbid than having all your lymph nodes removed. And it's important to note that the sensitivity of a test is in the context of the likelihood of the cancer having spread. So if you've got a 1 millimeter cancer, the chances of it spreading to your lymph nodes are almost 0. So therefore your sentinel lymph node is going to be almost 100% accurate, because it's either saying it's truly accurate or it's missed it, but it's probably going to be negative anyway. If you've got a 15 centimeter cancer, which has got a very high likelihood of having a nodal positive involvement, and your sentinel lymph node is negative, you're going to have a false negative there, because it's a very strong likelihood that that patient has got lymph node metastases. So again, you probably don't need to get into the minutiae of this, but the sentinel lymph node is thought to be a safer, effective, and lesser technique than the axillary clearance. And nowadays, we only reserve axillary clearance for those women who have got sentinel lymph nodes that are positive. That's it in a nutshell. And as I mentioned to some of the groups, there is a third option. You don't have to decide between sentinel node biopsy or axillary clearance. In those women who have got 1 or 2 lymph nodes positive at diagnosis, they can have neoadjuvant chemotherapy, and you can do your sentinel node biopsy after that in the form of a targeted axillary dissection. And if that's normal, then you don't have to remove all the lymph nodes. But essentially, the take-home message is we don't do axillary clearances on everybody, because most of the time they're not helpful and they can cause a lot of problems. And a sentinel node biopsy is a very small operation which can spare the majority of women any axillary clearance.
Okay, there's a few more questions. There's a couple of questions about inflammatory breast cancer. We've mentioned it because if I didn't, you would have wanted me to. We're not going to talk about it anymore because it's so rare that it's just not that important. So for Mr. Patani, how much of the Nottingham Prognostic Index is worth learning for these guys?
Okay, so that's a good question. So the Nottingham Prognostic Index has stood the test of time. You know, this is something that's based on the size of the tumor, the grade of the tumor, and the number of lymph nodes involved. I wouldn't commit the thing to memory, but it's so easy. I've almost committed it to memory just thinking about it, because you basically add the grade as it is. I think you times the size by 0.2, and then you just have to remember the groupings for the lymph nodes. And I think I can't remember it exactly, but I think it's not a difficult thing to remember. I think there's only 3 groups of lymph nodes or something, and then you can work out the score. I don't think they're going to ask you to calculate it, but I seem to remember that the high risk is above 5.4 or something, and there's an intermediate risk between 3 and 5, if I'm not mistaken, and there's a lower risk group. But it really has stood the test of time. So I wouldn't be obsessed about it, but be prepared to explain it. And it's this integration of clinico-pathological features that's proven to be really powerful. And it performs very well, even compared to some of the molecular profiling tests that we do almost 20 or 30 years later. So I wouldn't be obsessed about it, but basically you can add the grade, it's 0.2 times the size, and then there's a number that you add on based on how many lymph nodes you have. And if you explain that to the examiner and say it gives you an outcome of low, medium, or high risk, most people will be very happy with that answer.
Would you please comment on breast in the UCL OSCE? So my year missed out on it, so I have no experience to comment with.
So sometimes they do tailor your OSCEs based upon what you have and had not had exposure to. So I don't know whether it's going to be particularly prevalent in this year's exam, because I think people know that you've missed out on quite a lot of breast. The only thing I would say is that breast patients are well, healthy, usually very nice people who are ambulatory and would bend over backwards to help the medical school. So it's amazing how these disproportionate groups come up in your exams, because they're just easy to get hold of. There's lots of them, and they're happy to show you their scars and talk to you about their treatments. And they'll have little dots on their chest from radiotherapy tattoo planning, and they might have a scar on their back or their tummy from a reconstruction, and there'll be lots of things there to talk about.
Interesting. Okay, so maybe an examination discussion about management of breast cancer and such. We, I think, are at the end of things. So thanks again, Mr. Patani, for joining. Your answers have been fantastic to listen to, really enlightening. And the feedback as well. In fact, I've looked at a few of the comments. You were great. Thanks a lot for running this. Mr. P was amazing. Please say thank you. Mr. Patani was awesome. Thank you, Tim, for answering all our questions, and thanks to you guys for running the session. It's been our pleasure. So yeah, cheers, Mr. P. I'm going to stop the recording there.